Good afternoon, everyone. Hi, everyone. Welcome. Thank you for joining us for our first webinar day of 2025. So welcome back. Okay, I think that's everyone. Let's get started. My name is Rebecca Dunstall. I am clinical specialist at Careflex and I'm a physiotherapist by background. And we wanted to kickstart the year with a really interesting talk about, I guess, a client group, individuals who may be quite a typical individual that we might see who is in need of postural care and, of course, specialist seating. So we're going to be focusing on transforming postural care for individuals with neurological impairments. Just a bit of housekeeping before we start. We are recording the session, so if you could make sure that your mics and videos are switched off, please. You will, of course, get a copy of the presentation sent to you after the session, and I'll probably put a bit more detail in there to see if any trends come up in the chat function. So please do use that. My colleague Kiwi is monitoring that. If there's any issues, then please do chat to her on there. If I mention any terminology or resources, then mention it, and Kiwi and I will check through that at the end and get it all sent out post-event along with the presentation. We will have a little bit of a Q&A at the end, depending on how long I talk for, but we'll work our way through the presentation together. There is a lot of detail. It's obviously a lot of information for a very short amount of time with you. So again, if anything comes up, anything client specific that we don't quite have the time to chat about in detail at the end, and then you'll have my contact details and the team's contact details to get in touch with us, and we can liaise with the local seating assessor if there's any specific needs there. So let's get my presentation up. Okay. Hopefully that's loaded now. There we go. Okay. Now, before we started, I just wanted to really highlight our plans for the rest of the year for 2025. I returned from maternity leave last year, so we are kickstarting our roadshow workshops for the rest of the year, which will go along nicely alongside these live webinars, which will continue monthly. But I just wanted to highlight maybe there might be a bespoke need for training as well, and we've got the opportunity to do that. So the live webinars, dates for your diaries, you know how to register now, but please do feel free to share the information as well so that others can register. The roadshow is really exciting, traveling, as you can see, around the whole of the UK, doing these roadshow events, which are full day training days that really put into context all the theory that we kind of do in these webinars. So you'll hear me mention things about assessment techniques and seating prescription and seating solutions and risk factors. Well, these roadshows are an opportunity if you feel that there maybe is a gap in your knowledge or your skill set there, you can come along to those events, and we do them as workshops where we review the theory, but obviously then go into the practical elements, and we can use that through the chairs and having your local seating assessor on board as well to help with that. So you can build that connection and chat about any client needs. But then we also have the lunch and learn sessions, which are primarily led by our specialist seating assessors. So the aim is to empower you and your team to lead seating assessments, but to really feel confident in using the chairs and being confident in developing those care plans so you can hand those skills over to the support network as well. So when you leave that environment, you know that chair is being used appropriately and safely on a day-to-day basis. So the seating assessor will bring along those chairs, and it'll be an opportunity for you to get hands-on, see the ins and outs of the chairs, but then also covering, of course, the postural care and the pressure management element as well, and even maybe touching on some hints and tips around moving and handling and how to utilize the chair and integrate it with other equipment as well. So if there's something you feel there's a bespoke need in your area with your team where you need a bit more of a closer, more detailed look at the chairs in smaller groups, then please do reach out to us for those lunch and learns, and we'll of course provide the refreshments as well. So I wanted to, I'd done the talk at the OT show last year, and I really promised myself at that point that any opportunity that I had when I'm doing these educational events, that I would start by emphasizing this really, really important point, that body distortion is not inevitable despite popular beliefs. With the right equipment and appropriate positioning techniques, we can help to protect body shape, regardless of how complex an individual may appear, or how severe the damage may be to their body systems. If we are proactive in identifying that risk, we can protect their body shape and reduce the impact of those issues becoming severe fixed deformities. So please do remember that if we are proactive with our strategies, and we I guess put that responsibility on ourselves to identify risk of those who may be at risk of body distortion, and be timely with that approach, then we can help to protect their body shape. So let's kickstart our session for today. And hopefully by the end of it, you'll appreciate the impact of postural care, and specifically seating, on well-being and, of course, quality of life. Recognise the importance of the need for that holistic approach to postural care and seating provision. Highlight how the assessment will inform the seating prescription. And then, of course, identify the key postural challenges that you may come across with individuals you work with who present with neurological impairments. Now, I love this quote by Hippocrates. It's more important to know what sort of person has a disease than to know what sort of disease a person has. Now, I know we are going to be focusing on particular conditions and diseases and diagnoses today, but I just wanted you to remember, and what you'll notice is that there is a lot of overlap between maybe the problem list and the seating solutions that go along with that. So just really take on board that we can use the diagnosis to help guide the prescription. Of course, knowing about prognosis and rehab potential, and how things may progress or regress is really helpful for long-term planning. But in terms of the assessment and prescription, we just need to look at the person sitting in front of us. We could be working with two individuals who've experienced stroke, for example, and they will present very differently. So remember, try not to get too focused on what we expect a condition to be and the challenges that may come with that, and just look at the person in front of us, and come up with that detailed problem list, and come armed to the seating assessment with that, so you can come up with the solutions with the seating assessor. The way we do that is to prioritise the individual. Now, this is a true holistic approach to postural care, and what we found is that, of course, we can focus on the physical presentation, and as a physio, that's, of course, a priority of mine to have a look at the body system and the segments, but for effective provision of seating, and particularly in putting postural care approaches in place, it has to be holistic, because ultimately we need to understand what daily life is like for the individual, understand their expectations for that piece of equipment, because that's how we get compliance. So, for example, if you're working with an individual who's a wheelchair user, they don't have any other alternative seating, we know that they need a specialist seating system in place for a change of position. But if we don't find out what their expectations are, and understand what daily life is for them, then they're simply not going to use that piece of equipment. This individual, their main activity could be helping their mother in the kitchen. So participating in that daily activity gives them that sense of well-being and meaningful life. Now, if we supply that seating system without a tray, something as basic as a tray, we suddenly might take that away from them. And one, we're going to be affecting the quality of life, but two, they're just simply not going to use that piece of equipment. So it's really important that we get that person-centered approach and ask the questions about what you expect from this piece of equipment, and try and input that into our clinical objectives, because that's how we indirectly achieve them anyway. We need that consistent use. So just be mindful of that. Now, the way we do that is through a comprehensive assessment, which is split up into the subjective postural assessment. So essentially the history taking part, where we really find out about the individual, about their caregivers, and understand what their goals may be and what their preferences may be, looking at their history, their presenting condition, any relevant past medical history, such as surgery or pressure injuries. We look at their social history. Where do they reside? What does their support consist of? who are their main caregivers, because in some cases, especially with individuals who may present more complex needs, we do rely heavily on that support network. An important question to be asking is about their cognition and communication. So not only their capacity to understand and consent, because of course that opens up the need to discuss things like best interest or guardianship, depending on where you are in the country. But before we get hands-on, we have to know, and this is a tip really, a takeaway message, find out how they communicate pain before we get hands-on and do that physical assessment. I've worked with individuals who giggle or laugh when they're in pain, and if I didn't ask that question, I would assume that they were comfortable or happy with that piece of equipment. So it could be a particular gesture or a vocalization or a noise or a word or a sign that they use to communicate that they may be in pain. So just make sure you ask that question. We, of course, spoke about function and that meaningful engagement in daily life. Moving and handling, this is all about safety, how they get into and out of the chair, and how we might need that seating system to integrate with other pieces of equipment. The current equipment can be a really good guide as well. It can give us an idea of maybe what their habitual preferred posture is, certain signs of wear and tear or compression on one side of the cushion or scuffs on the arm of the chair could give an idea of how they tend to sit within that piece of equipment, and can just help guide the assessment process. But also their likes and dislikes as well, and maybe the aesthetics, which we'll chat about later, can play an important part in that compliance. And then there are going to be some considerations and contraindications we may need to think about if we're looking at particular functions like tilt in space or the type of materials we may need to use. Continence, body temperature regulation, swallow dysfunction, so dysphagia and the risk of choking and aspiration, medical devices that are in situ, and so on. And current pressure injuries as well. That's obviously going to impact on our provision and the care plan as well. Then you have the objective postural assessment. This comes before the seating assessment. So it would be a case of, as clinicians, we've got the responsibility to come up with that problem list, to come armed to the seating assessment with the seating assessor already with that problem list, because the seating assessor is going to be the chair expert, and then we need to work collaboratively and bring those challenges to that seating assessment, because to be able to maximise the time with the chair, because you won't have the time or the resources to be able to find out the information you need, like critical angles and postural support needs at that seating assessment. So the postural assessment comes first, and then the seating assessment. Finding out things, as I said, about their habitual postures, getting them out into supine lying, see how close we can get them to that anatomical position, to that midline neutral position, what the body limitations are, how much can we correct or do we need to accommodate. Thinking about the critical angles for sitting, hip flexion, knee flexion, the position of the feet, and so on. Then also the postural support needs as well. What's their sitting ability like? What's their postural control and balance like? The proprioception, are they aware of where that midline is? How much support do they need at the trunk, and where does that need to be applied? So then we can replicate that within the seating prescription. Outcome measures are really, really important as well at this point, getting that objective data so you have that baseline, so that when you have that robust review process in place, you've got that comparison to look back on to see whether one is the piece of equipment that we put in place doing what it's intended to do. Has it made things worse, or if there are any changes that get highlighted, because we aren't static, everything is dynamic. Somebody might have another neurological event or an acute illness that makes them confined to their bed for a period of time. They may lose weight or gain weight, so we need a robust review process in place and that comparison to the baseline to be able to have that marker to measure effectiveness. And we also need to consider the sensory system as well, depending on how they react to certain pressures or the tactility, or even whether they prefer deep pressure. So we need to think about getting the seat dimension snug, or whether they respond better to light touch, in which case we need to open up the space a little bit more so they don't feel so confined and rigid. And then once we get that information from the assessment process, that's how we get our effective seating provision. And this really follows 4 steps. And those 4 steps are going to be the same for whatever individual you work with. First of all, the basics, which sadly do often get overlooked, maybe because there is a training need or a gap in the knowledge, especially within care teams or care homes or with the caregivers who are using the piece of equipment on a daily basis, especially multi-user environments where maybe you have one chair between several residents, for example, and them not feeling confident or competent to change the basic dimensions in between each user. But we really have to make sure that we get the seat width and deep seat depth correct as a minimum, because it will influence the position of the pelvis and the postural stability within the chair. So, for example, if you have a care home where there is a 6-foot individual and a 5-foot individual using the same chair, the 6-foot individual uses a chair and the seat depth is great for them. They can flex their knees and get their feet on the floor. But then if it's not adjusted and the 5-foot individual sits in the chair, suddenly their legs are extended straight out in front of them. And just to be able to bend their knees over the edge of the cushion, they have to slide down and shuffle down into that posterior pelvic tilt, into that sacral sit-in. So suddenly this significant postural challenge has been created just because the basic chair dimensions aren't appropriate for them. So that might be an important part of the care plan to be mindful of. And if there are any particular training needs, and again, reach out to us if you have CareFlex chairs within care homes, or you're concerned about a care team, maybe where there's a high staff turnover, then reach out to us. We go out to nursing homes and care homes and residential homes to do these training sessions with the care team, and to hand over any insights on the ins and outs of using the chair on a daily basis. We then have the choosing the appropriate seating solutions. So as I said, as clinicians, we have that problem list, and then we work with a seating assessor collaboratively to come up with those seating solutions. And we can only come up with those seating solutions if we come prepared with that problem list, understanding the body limitations and really asking ourselves, what can I correct, or what do I need to accommodate within the chair? Then this comes on to the safe use of functions and accessories. So we've decided on the chair dimensions, the basic setups, such as the choice of back support or cushion, for example, and postural support and leg rest. And then we're thinking actually we maybe need to utilize some functions such as tilt in space or back angle recline or leg rest elevation. And those are 3 functions that will need to be risk assessed to make sure that they are safe and appropriate for the individual. For example, there might be some individuals who we need to limit the amount of tilt is suitable for them, especially if they have a catheter, because we don't want to increase the risk of backflow. We might have individuals with dysphagia, so there's a risk there, or maybe a history of choking or aspirations, in which case we need to be mindful of how much tilt is safe, especially around meal times, and making sure that's reflected in the care plan, and utilising our MDT where possible, the expertise of speech and language therapy, for example. All of that then leads into the final step in making sure we have that clear, concise care plan, so that anyone who's working with that individual or supporting them sees the chair and knows exactly how to set it up, how to use it, what can be used, what can't be used, do we need to lock anything off, and using timetables where appropriate if we are looking at a gradual increase the tolerance of the chair. So a gradual introduction to that piece of equipment, we need to build up that time that they sat out, and using timetables to do that. And of course, if somebody does have a then even more detailed 24-hour postural and pressure care approach, of course, that timetable is going to be critical, knowing when to move between different pieces of equipment, when to utilize function to change that regular change of position. And then, and this is just a really helpful checklist when we talk about the seating prescription and the care plan, is making sure that we meet these key principles of seating. It's not just about posture, of course. That's an important part that as a physio and as a clinical specialist within specialist seating, I'm going to be pushing forward in terms of that postural support at all body segments, but it's just a part and a piece of that puzzle. At CareFlex, comfort is actually our top priority. Research has found that regardless of the clinical benefits, if the user's not comfortable, they're simply not going to use that piece of equipment. So comfort, top priority, and understanding how we communicate with an individual to know that they're comfortable as well. So we need to get that checklist off. The posture, of course, and the pressure care, because they are inextricably linked. The function that we've already touched upon, having meaningful part in daily life and being able to increase that independence and inclusion. But it also means that if somebody's functional, it means that they move in their joints through range of movements, but also protecting the body parts as well and reducing the risk of injury and severe deformities. We've of course got safety. not only safety within the chair, but transfers into and out of the chair as well, thinking about falls risks and how that might impact on that. And then, of course, well-being, which is a vital part of quality of life, and something that we need to make sure the chair promotes and enables rather than restricts. So if somebody needs to be able to maneuver around the environment, to access different rooms of the home with loved ones, and we need to find a way to enable that. If they want to partake in activities or occupation, we need to find ways of doing that with the seating solution. Research has shown that isolation and loneliness is twice as harmful as obesity is to physical health, which is staggering. So we have to make sure that we enable that, and this is the puzzle we put together. Right, that's a lot of me talking, and there's going to be quite a bit more of me talking as well when we go into neurological impairments. So I am a physio, so I just wanted to do a quick activity. If you are able to join in on this, please do, but be mindful, please, of your own body systems and don't do anything you think is going to cause any problems. But this is just a really good activity that I like to do in any of our training days, with clinicians, with caregivers, with individuals, to put ourselves in somebody else's shoes and have a feel, just a really brief feel of how posture can impact on an individual. So if you're able to, please adopt a destructive sit-in posture. Maybe you have a kyphosis, quite a significant kyphosis, which is affecting your neck, so you're going into that hyperextension as well, and you've got a bit of wind sweeping and lateral flexion happening because gravity's having that impact on you. And then imagine then, when you think about the environment as well, that suddenly your point of view, if you can move the screen or move your chair and try and still look at me, and how that then impacts on your ability to interact with the outside world. And then I'm going to make you sit like that for the rest of the talk. I'm only joking, I'd never do that. But if I did, can you imagine sitting like that for the next half an hour, the next 6 hours? Tomorrow for another 8 hours, and so on. So it's just really important that you get a feel of how, not only for the individual, think of the pain that would come with that, but not being able then to partake in daily activities, but then how those fixed postures can have an impact on their health and safety then as well going forward. I guess the responsibility on us in terms of risk mitigation for avoidable harm. There's a lot of legislation in place around that. So we have to take that responsibility to identify those risk factors before we get to that point. So that's our overall goal. Be proactive, identify those who might be at risk of that happening, and being timely with our interventions, and getting postural care in place before that happens. Okay, so please check your postures, make sure you're all comfortable. And let's get into neurological and neuromuscular conditions. Some of the most common ones, of course, there's many, many more that you would come across, but in terms of maybe the most common, in terms of the frequency within the client group that we might come across. So Huntington's disease. I'll briefly I'll be sending out this presentation. So what you will see is a bit of an overlap. So going back to that quote from Hippocrates about seeing the individual in front of you, well, what you'll see is quite an overlap in terms of neurological impairments in the type of postural challenges that may be present, and obviously the seating solution goes along with that rather than the diagnosis. So you will see a bit of an overlap, in terms of the neurological impairments and how they impact on an individual with a particular diagnosis, it just may mean the priorities change. So there may be a particular challenge that's actually more impactful on their daily life than something else, but a lot of them you'll see a bit of a theme happening. So Huntington's disease, neurodegenerative disorder of the central nervous system, inherited condition that both men and women can develop, where we gradually see damage to the brain over time that can affect things like movement, cognition, and behaviour. Now, in terms of postural care, probably the biggest challenge that we see is those involuntary movements. So those create movements that can maybe seem sometimes quite erratic, sometimes quite violent, and how that then, of course, has an influence on pelvic stability, their sitting ability within the chair, safety, and especially if they're still ambulant or semi-ambulant, how that impacts on their transfers. So that would be probably the main postural challenge for Huntington's disease. We of course then also have, because of sometimes these involuntary movements, we can see fatigue happening because of the energy expenditure, weight loss as well. So we need to be mindful in terms of that robust review process and maybe having to make adjustments depending on their body shape and size. Fatigue management strategies to help to manage that. It might be a case of utilising certain functions if it's appropriate, or it might mean a change of position. And what you'll find with postural care, 24-hour postural care, it's okay to have this change of equipment. If somebody needs to go into a supine positioning with positioning aids in bed for a period of time to recuperate, but also to extend out and get blood flow to the areas for a certain time, then that's okay during the day. It's just about that regular change of position, utilising the wheelchair, the bed, alternative seating, maybe other therapy products, tilt tables, and so on. With Huntington's disease, in the end stages, we might see this more massed flexed posturing as well. So just be mindful of that we may need to think long term about if somebody might develop a kyphotic posture, do we need to try and utilize tilt and space? But what we've actually found is we tend to have more of an impact if we come anteriorly and offer that anterior support to open up the shoulder girdle using a tray or a padded tray with a V cushion to help prompt that position, can sometimes be more effective and actually more functional than tilt in space, because there's so much that you can't achieve when you're in the tilted position. You prefer to be upright. And you can then progress onto positioning aids if maximised control is needed, so pelvic belt with a chest harness, for example. So as with anything, when we talk about that flow of seating provision and how we get that effectiveness, correct seat dimensions, the basics, getting that set up so we can get that pelvic stability. The pelvis dictates what happens to the body segments above and below. It's the core for sitting, and will influence the spine, the head, the lower limbs, and the feet. Pelvic stability will also impact on function, because if somebody doesn't feel stable within the chair, we suddenly see the upper limbs becoming that load-bearing role. So we need to get that pelvic stability so they're free to move the upper limbs and engage in function. So you have to have that proximal stability to get distal control. So it's not just about getting somebody's bottom in the back of the chair. It's actually about getting that pelvic stability. And there's ways of going from the least restrictive option and working our way up. So things like a ramped or angled base might be sufficient just to help prompt the pelvis to the back of the chair. We may need then a slight tilt to utilize gravity to keep the pelvis at the back, and then we work our way up then to positioning aids, pelvic belts, 4-point pelvic belts, groin harnesses, and so on. With Huntington's disease, we may need to think about transfers if they're remaining on their feet. So a negative angle leg rest can help, even if they've got the range at the knees. Sometimes a negative angle to be able to get a good stable foot position and get that grounding for a good safe sit to stand may be indicated. And of course, we need a robust frame with padded elements. So if pelvic stability is not managing to encourage normal movement patterns, and we still see in these choreic movements within the chair, then we need to protect them with padded elements to make sure that we're not seeing any injury to the body parts, but also pressure care as well. So if we're seeing weight loss, making sure that we got and there might be bony prominences to support that. Another thing as well that we might see within Huntington's disease is in the sitting process, where they lack that postural control, and we might just see them flop down in that one large movement within the chair. So again, that robustness might be needed. So something like the hydro tilt, which is a tilt in space only chair, because you haven't got the element of the back angle recline, it makes it a bit more robust within the chair. But also something like the Alpha Care as well, where we've just got the robustness there to be able to take those repetitive, sometimes quite violent movements. So then we've got multiple sclerosis. And again, it depends on the type of MS that the individual might have. Is it relapsing remitting, primary progressive, secondary progressive? Because that obviously depends where they are on the journey, what kind of postural challenges might be the priority that we need to address. But I guess one of the key things, regardless, when we talk about MS, is fatigue and energy management. And making sure, because if it's a new diagnosis, maybe they're not quite fully aware of their own energy expenditure yet, and how to manage that and what might be too much for them at that point. It could be that they go in through a relapse, in which case their presentation is going to be very different to when they're in remission. So we just need to be mindful of fatigue and the effects of gravity on their positioning. Gravity is unrelenting. If I made you sit here for the next 8 hours listening to me talk, I'm sure you'd feel the effects too, and they'll start pulling you down. The problem with gravity is it tends to exaggerate symmetry. So if somebody's already got a slight preference to which way they lean, it's just going to pull them more down into that position. So gravity, one of the things we need to try and counteract somehow. Do we need to offer more support during a remission? In which case, do they have two back supports maybe? Because what we don't want is to take away their active engagement either at times when they're able to do it. Do we need to add lateral supports for more support, but then can we take them away to get the core engaged and get them actively involved to maintain those functional skills and movements? We could see some involuntary movements as well to be mindful of, so we need to try and promote those more normal movement patterns as well. With individuals with MS, there could be sensory impairments that we need to be mindful of. Proprioception, maybe being effective, not knowing where their body is within the space. So in terms of specialist seating, again, you'll start seeing a bit of a theme here when we talk about pelvic stability, when we talk about getting the seat dimensions correct. But flexibility is going to be key. It's going to be about understanding the individual and how they present at different points within their journey with MS, so that we can try and maximise potential, but also support when we need it to. And that's the beauty of specialist seating, that we can make those adjustments. We can make retrospective changes, but they could also maybe have a stock of accessories at home to be able to switch in and out if they need to, and the care plan would obviously reflect that. Something like there's different back options. If you're new to specialist seating, Michelle Keevy will share some links about some of these chairs that I'm mentioning. The waterfall back can be really helpful, especially if they do present with a kyphotic posture, because you can remove some of that wadding, and you'll see that a bit of a link there, especially with somebody with Parkinson's disease, the same kind of process in terms of removing that wadding, so we can encompass that position if it's fixed. So ultimately what we want to do is correct the individual and take them back to the chair. But if we can't, we still need to fill in those gaps and accommodate by bringing the chair to them. With MS, you might be working with individuals who still participate within daily life. They still have a role within the community or an occupation, in which case we need to think about things like the addition of a tray to encourage that. And maybe they need environmental controls. Maybe they work from home and they need environmental controls, and we can integrate that within the chair as well, to enable that continued occupation. Next, we have motor neuron disease, which affects the motor neurons in the brain and spinal cord, and that's responsible for movement and control and muscle control. So what we can see, sadly, within MND is these messages become what we see is damage to the messages arriving from the nerves, and they gradually then stops reaching the muscles, and we can see muscle atrophy, where essentially the muscle can weaken or waste. And of course, with MND, like with any of these neurological impairments and neuromuscular conditions that we mentioned, it's going to be different for each and every individual. So the range of symptoms, the order of the symptoms, and the speed in which those symptoms come in is going to vary from person to person. So again, we're just working with the individual in front of us and being sensitive to where they are on their journey. But there could be a long list of things that sadly they could present with, and some significant postural challenges that we need to think about in both the here and the now, but also as it progresses as well. Pain, of course, fatigue, and then the muscle weakness that I mentioned, which will of course have an impact then on their positioning within the chair, being able to hold themselves erect against the forces of gravity, seeing the influence of gravity on those asymmetries, but then keeping them safe and stable within the chair. We need to be mindful of head position, especially with things like swallow, to make sure that's safe around eating and drinking, but also communication as well, because well-being is going to be such a vital part of this, and making sure that they're able to interact with the environment, communicate with loved ones, and participate really in meaningful daily life throughout that process. What we want to do is I guess identify the risk of contractures and deformities as well, and get interventions in place to reduce the impact of that, so that we can keep them as comfortable and as pain-free as possible. We're going to have, of course, I mentioned about the head position, so trunk alignment, postural control, in terms of them within the chair, but also the interaction with the outside world as well. Working with colleagues, and this is where MDT and that interdisciplinary working is going to be vital. Reaching out to speech and language therapy, physiotherapy, OT, tissue viability, and just really working together, come up with a plan to maximise the postural care that they have throughout our full 24 hours. And we may need to look at the integration of orthotic support, moving and handling advice for safe transfers as well, because there could potentially be a rapid change in their needs. So we need that robust review process as well, and the care plan needs to be adjusted to highlight that as we go through that. So stroke recovery and rehab, again, completely depending on the individual. No two individuals are going to be the same, because it depends on the location to the damage in the brain, the amount and the severity of the damage. Impact then on the types of signs and symptoms that we might see, and how effective, when we talk about hemiplegia as well, how effective one side would be compared to the other side. How that impacts on physiological function, so their health, to make sure that we are thinking about risk mitigation, reducing the risk of illness and future hospital admissions, and then finding out how we, across that 24 hours, how we maximise rehab potential, and we can work then and understand exactly what we can push the chair to do, to make sure we have those adjustments in place, so that we are maybe, where possible, taking support away. So they might need more support to start with, but we are reviewing it regularly and adjusting the chair. And that's the beauty, again, of specialist seating. We can keep adjusting to get them actively engaged, and hopefully seeing more rehab potential and working the other way, which is sometimes a fantastic thing to witness, and seeing those improvement. It might also be a case of thinking about the well-being aspect as well, especially, I guess, with any neurological impairment or condition. Is if it's a new diagnosis and they've never been around medical equipment before, how do we navigate that sensitively? Do we need to think about sharing information in leaflet form or videos before we go out and do these assessments, and show them pieces of equipment? Because it can be quite daunting to see medical devices, which is what they are, the medical devices, like a prescription, like as important as their medication is. And sometimes there is a bit of a need to come around to that. So it's just being mindful of that. So within stroke rehabilitation, again, seat dimensions are key, but that adjustability and being able to make those changes as that person goes through their rehab journey. We need to think about how it integrates with other pieces of equipment. If somebody may have other specialist equipment, shower chairs, commodes, it could be wheelchairs, and we need to think about how that integrates between them. You're making sure that we have the space needed and the turning circles, and if somebody is able to do side transfers, how we enable that. Do we need things like removable arms or drop down arms? And just thinking about all those little elements throughout that full 24 hours. And then we have Parkinson's disease, another neurodegenerative disorder, the central nervous system, and we see this progressive damage over many years. And signs and symptoms of PT, Parkinson's disease, usually develop gradually at first, and they may be mild, but then they vary from person to person in terms of the speed at which we might see that progress. But the main ones tend to affect physical movement. What we can see probably one of the challenges that we see the most within PD is those flexed kyphotic postures, so a stooped or flexed posture of the thoracic region, which obviously impacts on the head position and the neck, and the increased risk of that becoming fixed. So again, identifying risks and putting things in place and strategies and interventions in place to try and reduce that from becoming a major impact on their physiological function, on their swallow, their eating and drinking, but also their communication as well. We might see a scoliosis with that. So thinking about the spinal posture is a key part of the assessment process, and how much can we correct or accommodate depending on when you get involved. We need to think about the pain that comes with that. So comfort is key, as we know. We could see abnormal muscle tone, but also changes in proprioception, and we touched on this as well within MS, but having awareness of where their body is in space. So when it comes to the seating prescription, as with anything, we're of course focusing on the environment, but with Parkinson's disease, we've worked with an individual who responded really well to having a mirror in the room in front of them, so they can have that visual prompt to know where their midline position is, especially if they haven't got that regular verbal prompting that might be needed if they are seeing that as a challenge to know where their body is in space. But of course, we're supporting all body segments. We still have that adjustability and flexibility to change in need. And I mentioned about a waterfall back with Parkinson's disease. If we do have those kyphotic postures, we can mold the chair around them by adjusting that wadding. If we can't correct them, which is of course our main goal, is trying to bring them up, giving them that anterior support. Okay, so that's a lot there about and kind of a whiz through in terms of neurological and neuromuscular conditions. But I just wanted to really highlight some other client groups that maybe you're not so aware of, or it might be more difficult to understand those neurological impairments because they may be masked or hidden because of their presentations. So I just wanted to highlight some individuals just to make sure that we're not missing anyone, that nobody kind of slips through the net. So I'm going to chat about some of these in a bit more detail. So first we have learning disabilities. So it's any form of reduced intellectual ability that challenges everyday activities and affects the way that a person learns new things in life. Now, of course, postural development comes from learning. So in the general population, we learn from and respond to information from various sources, like a visual feedback, a proprioceptive feedback, to be able to learn about our own posture and our own posture management. If somebody obviously has learning disability where that impacts on their learning, we're going to see problems with their postural development as well, and their global development delay. So I just want to be mindful, because neurological impairments then may be masked or hidden by that process. There are different types of learning disability: mild, moderate, severe, and then PMLD, which is profound and multiple learning disabilities. And they will need more support than general population. And research has shown, and it's pretty self-explanatory, that people with learning disabilities have greater health needs than the general population. So we've got a responsibility really to support these individuals. Even if you don't work, I come from learning disability specialty. That's been kind of what I specialise in as soon as I graduated many years ago now. It's a personal driver for me as well. My younger sister, has profound and multiple learning disabilities. So I can kind of see things from both sides, and I probably have that motivation, a bit more of awareness if it's not something you've ever had access to. But even if you don't work within learning disabilities, you're still going to come across these individuals, and it's still your responsibility to work with them. If it's not the learning disability, so for example, if you're working within an MSK, a musculoskeletal environment, and somebody comes with a learning disability, comes in with an injury, maybe a knee injury, that's obviously knee injury and stands alone by itself. It's not impacted or caused by the learning disability. So we still have a responsibility to support them with that. And sure, we can lean on colleagues who maybe are on learning disabilities to understand a bit more about communication. But if our expertise, such as it is within postural care, is that, then we need to still support them. So I wanted to highlight that around learning disabilities. What we might see within this client group is cerebral palsy, CP, but please remember that somebody who has CP doesn't always have a learning disability. So just because they have CP doesn't mean they have a learning disability. So just be mindful of that the way we interact with individuals, and that's why it's really important that we find out about their cognition and communication before we make any assumptions on that. So cerebral palsy is an umbrella term for a group of lifelong conditions that would have happened during, before, during, or soon after birth. There are different types of CP. One of the ones you've probably heard of the most, spastic quadriplegic CP, where you have the wheelchair users where all four limbs are impacted by the CP. But the problem list, the postural challenges are going to be different for each individual. There could be individuals with different involuntary movements, with spasticity, with extensor spasms. There could be individuals who are still mobile. They could be diplegic, hemiplegic, so it completely depends on the individual. So don't make any assumptions, just treating the individual in front of us. We could have somebody with very mild postural challenges all the way through to the most complex. So again, it's just about coming up with our problem list and working together to come up with a seating solution. So there's a whole host of lists there that's not going to be relevant for everyone, but just to give you an idea, it could be anything or everything. But the seating prescription and the process that we go through for the provision is going to be the same in terms of meeting those checkpoints, basic seat dimensions, making sure it's safe and use appropriate of functions, that the care plan is robust and we're meeting their holistic needs, and finding out and communicating with them, but using the caregiver's expertise as well to find out what they expect from that piece of equipment. Another category that kind of falls into maybe not less obvious, but less prominent when we talk about neurological conditions that we might come across and define diagnosis like Parkinson's and those lifelong conditions, but actually traumatic brain injury as well, where sometimes they can kind of slip through the net if there's not a specific team, like there might be a stroke rehab team for somebody with stroke, or there might be MS nurses to help those with MS. In certain areas, what we found across the country is those with traumatic brain injuries or spinal cord injury can sometimes lose that support, especially when they leave the hospital environment. So just be mindful of these individuals and identifying risk, because they can actually present with some of the most complex postural challenges that we see. So poor postural control, and again, depending, especially with spinal cord injury as well, depending on the location, the severity, is going to affect obviously how they present with it in front of us. But what we need to be mindful of is that risk of severe fixed deformities and contractures happening, and how we implement things in a timely manner before that happens. And then the final one I wanted to cover is individuals with autism, also known as autism spectrum disorder, or ASD. These terminologies are changing all the time to reflect the true identity of these individuals, but essentially a lifelong developmental disability. It's a spectrum disorder, which means there's going to be, again, a wide range of symptoms that vary in form and severity. But what we do tend to see is this impairment in social interaction and communication that affects how they interpret and how they experience the world around them. But just remember that with the right support, the same with anything that we mentioned today, with the right support, individuals can live a meaningful life, a full and meaningful life. Now, what I wanted to highlight really when it comes to ASD, when it comes to postural care, is that we will need to change our approaches to make sure that we are maximising the time that we have with them, and targeting the right areas in terms of the seating prescription. So our approach may need to change. So we might need longer appointment times. We may need a few visits to improve the familiarity for them to even allow us to get into the same room as them, to get hands-on with them. We might need to think about our assessment techniques and how we do that a bit more remotely. Do we need to change location? So again, it's somewhere that's familiar to them, a certain time of the day that works for them, that they may be better engaged with us. Do we need to think about the support network that comes with them? So it's just think about all those approaches really beforehand to maximise the time that we have with them. But then when it comes to the seating provision, this is the point where we can say no to brown and black materials. So if we're working with individuals where there is an issue with the aesthetics of the chair, the tactility, a particular fabric or print or colour. This is where we use our clinical justification to highlight the need to have a bespoke prescription for them, and we need to take responsibility for empowering that. Really, we don't have to just take off the shelf things if we know it's just simply not going to be used. One, that's not going to help the individual. It's certainly not going to be cost effective for the service provider, because we not only are we wasting time and resources with us repeatedly doing these visits, but also we putting things in place that cost money, that could be used elsewhere for somebody else, and then we're going to end up having to get the funding to put the original thing that we wanted in place anyway. If you need help with those clinical justifications, then again, reach out to us. If you have care flexibility and you're really struggling with that, then we can help with resources, with legislation, giving things in black and white, highlighting risks and consequences, and even helping with the cost effectiveness, so you can really highlight how actually, yeah, not only will this help the individual, which is why we're here, but actually in terms of service provision as well. If we get the prescription right at the right time, then I think we need to think long term about this. Not only does it help the individual, but it reduces the complexity as well. So it's a lot easier for us as clinicians to be able to assess less complex postures, to be able to put in place less complex seating solutions, and they obviously cost less to the service provider as well, and the care package is going to be less. So if we identify risk and be proactive and get these things in place in a timely manner, it's just going to help the whole wider community, and make sure that we have these resources for a long time to come. But again, we can help with that. We've done lots of projects and stuff, and helped NHS trusts and social care providers to really emphasize and illustrate this from a business point of view, as well as the human cost as well. One thing I always say about pastoral care, to be truly holistic, we need that MDT approach. I hope you do have the opportunity within your clinical practice to work with other professions, to have that peer review, and to collaborate with OTs, physio, speech and language therapies. If you find that you are alone working, then maybe just spend some time to locate a champion within your area, even if you're only meeting up once a month or twice a year, to just really brainstorm together and have that peer review, and learn from each other and bring some challenges, because it truly will elevate what you're able to do with individuals from a postural care point of view. And then finally, everything we do is, of course, person-centered, but when we talk about some of these neurological impairments, and maybe some individuals who do present with the most complex presentations and challenges, we do sometimes heavily rely on the support network, on the caregivers, on the care team, on loved ones, to be able to implement that care plan. So if an individual can't follow it themselves, or if they actually need prompting or full assistance to follow their care plan, we need to build that support network and give them the confidence and competence as well to be able to follow it on a daily basis. And again, we can support with that if there's any training needs, as part of the delivery process. Whenever the seating assessors or the engineers go out to deliver the chairs, that's a key part. It's a key point in the checklist. It's not just a delivery, it's actually addressing any of those training needs as well, and make sure everyone gets that hands-on opportunity with the chair so that they feel confident in utilising it. But as clinicians, we need to make sure that care plan allows them to do so, giving them risk factors to look out for. Who do they contact and how do they contact if they're concerned about any changes, and then how to use it, to use the chair within that 24 hours. Given outcome measures and timetables, photographs, they are fantastic in terms of getting that initial positioning right, if we can supply that with the care plan. And then there's our continuous evaluation that I think I've said enough times, having a robust review process in place. We're not static, everyone's dynamic, conditions are dynamic, lives are dynamic. people can experience new acute events or illnesses that can take them back, or people can have rehab potential that we never expected, in which case we want to address that and enable that. So just having that process in place to make sure that there are those points of contact to keep on top, because a chair sometimes does need to change to match the individual, but it can also be cost effective as well, especially if in multi-user environments where we are maybe recycling and refurbishing. Get in touch with us and see how we can maybe adjust chairs to suit other individuals. So in summary then, just nice little pointers here that hopefully you've taken away from this session. I apologise, there's been a lot of me talking, a lot of information to get through, and I could keep talking a few more hours, but I won't keep you here. You will get copies of this presentation, and I'm sure Kiwi's been on top of the chat function. If there's any resources that come up, we will share them with you. So C, the comfort is of course top priority. Enhancing their well-being through comfortable and supportive seating means we have that compliance with that piece of equipment, which is obviously a critical part of actually achieving our clinical objectives. We've got their health, especially when it comes to neurological impairments and the impact on physiological health, safety with swallow function, cardiac efficiency, digestion, and reducing the risk of things like constipation and digestive issues. We need to address that and protect overall health and all those risks associated with that for risk mitigation to avoid harm through utilising postural care interventions. And again, that's by being proactive. Ability, so we want to maximise their functional ability to engage in tasks and participate in daily life. So that's so important for their well-being. Individualization, so regardless of the diagnosis, as I said, it can help guide, but we provide seating solutions for the individual sitting in front of us, and it's tailored to their unique needs always. And then risk reduction, so again highlighting the need for proactive risk mitigation and avoidable harm with this timely appropriate provision, not only for the individual but for our working practices and service provision as well. And just to remind you how we can help, because we are here, as I said, we've got this strong educational program in place now. We've got the webinars that are going to go lovely alongside our roadshow workshops throughout the year. We've got the lunch and learn opportunities, and we've always got the bespoke. So if there anything does crop up that's client specific, just reach out to us and we go through that together, and we can brainstorm and peer review and come up with those solutions. There will be ad hoc training events happening. The website has got a whole host of stuff, so a lot of the resources I've mentioned will be on there. Lots of blogs and articles. We've got guest OTs doing fantastic blogs for us as well, just so we've got that perspective from different areas and different practices. Clinical justification documents for each of the chairs. So if you are prescribing CareFlex seating, you need help with funding, a bit of a cut and paste exercise to help you get that piece of equipment in a timely manner. Encyclopedia specialist seating, we've got the pocketbook, which is a lovely little reference thing. A lot of what I touched on today around assessment techniques are in there, so you can take that out and about with you. And then just remind you of all those events. And when you get a copy of this presentation, you'll see the information on there, contact information, find out how to register, a bit more information around the resources and the reference list as well. That's a whistle-stop tour of neurological impairments. Thank you so much for listening to me. Kiwi, is any trends in the chat? Any specific questions come up?
Yeah, we did have one or two. Is there any specific guidance re-seating for patients with DOLs?
I'm assuming you mean, is it deprivation of liberty?
Yeah, sorry.
Yeah, that's that what I mean. Yeah, I mean there's plenty of legislation out there that you can lean on. I mean, it depends on where you are in the country, because obviously it depends on which legislation you access. Coming from working in England and Wales and working closely obviously with the learning disabilities, the issue there around best interest as well, and the numerous meetings that you do have to be involved in and making sure it is the best interest decision with the support network, the individual, and the clinicians as well coming up with that as a plan together. So yeah, there are legislations out there that can be accessed. a lot of it comes from that MDT working and supporting each other as well. But I guess it depends on the specific decision. So, for example, I'm sure most of you know this, when we talk about best interest, it's about a particular decision. So it's not just, do they have capacity to use this chair? We actually have to go into the specifics. So do they have the capacity to understand the tilt in space and how to use it? Do they have capacity to understand, or do they have the capacity to consent to a pelvic belt? And you have to really break it down to each of those decisions. So if the person who asked this question has specifics, then please do email me and we can look at that in a bit more detail. I guess a lot of the issues around deprivation of liberty would probably come from the positioning aids, and making sure that they are used appropriately when we talk about restricting the processes that could come with that. But of course, it's about our clinical justification as well, and making sure we understand why we are prescribing. Don't get me wrong, there are extenuating circumstances and exceptions to the rule where I have worked with behavioural management teams, where of course there are restrictions in place, but that's a very rare exception. Otherwise, whatever we prescribe in terms of specialist seating is positioning aids. It's not to hold somebody within the chair, it's actually to protect their body shape. And I guess we need to differentiate that. So if that individual has specifics they want to ask, then yeah, just send me an email or send us an email and we can chat about what it is particularly you're concerned about. But it's just about breaking that down really into the set decisions. I hope that answers the question. It's a bit of a how long is a piece of string question. So sorry I can't be particular. So if I need to know the specifics on the individual.
Brilliant, thank you. We had one more, which is, are there any other anterior support solutions that can assist to correct kyphosis before progressing to reconfigured waterfall backs?
Yeah, so in terms of the anterior support, what we've found, again, this is just, I guess, from case studies and working with the seating assessors and feedback we've had, and outcomes that we've seen with our seating. What we found helps the most is having a tray, could be a padded tray with a V cushion, so that they have support for the upper limbs that prompts in that position. Chest harness, you can obviously work your way up to positioning aids in terms of pelvic belts and chest harnesses to get that anterior support, but sometimes that can restrict the functional ability. So definitely in terms of least restrictive option, starting with that padded tray V cushion and getting that prompt for the upper limbs to open up the shoulder girdle from that point of view, because then they can still stay upright, and you've still got the functional movement. But then if somebody does need to maximize that control, you can work your way up then to positioning aids. Using a visual prompt as well can sometimes help. So if there is a point of interest within the room, maybe taking the eye line up a little bit to encourage that, especially if they're still actively engaged and can still do it. But utilising the environment, if it's somebody who enjoys watching movies, for example, then maybe having the TV up on the wall instead to encourage that eye line can sometimes help, and think about the environment and just clever ways of doing it that way.
Someone added, so would the V cushion be placed on top of the tray?
Yeah. I mean, some people have had it on their laps, but it tends to be, I mean, what we found anyways, doesn't seem to be quite high enough to give that prompt. And what you see is the upper limbs just sinking into it. And whereas if you have the tray, which is a firmer base for the V cushion, it gives a bit more feedback and prompting into that position.
Brilliant, thank you. That's all I've got question-wise.
Lovely, thank you, Kiwi. As I said, if anything crops up, any other questions you've thought about, then all the details will be on there. Just reach out to us. Training needs. But thank you very much for joining us for our first webinar day of 2025, and I hope you will join us for the next one in February. But we'll send out all the details. We send out the presentation as well, and any resources that have come up. But thank you very much.